All right, so I'm thrilled today to have a good buddy of mine from way back on the show, Dr. Josh Roller. Josh and I did general surgery residency together in Dallas. I will let him introduce himself and then we will get into some questions. So, Josh, welcome to the show.
All right, thanks for having me. Dr. Josh Roller. I practice at Roller Weight Loss and Advanced Surgery in Fayetteville, Arkansas, and basically we focus on weight loss surgery, do some medical weight loss, and then all types of general surgery. And that's been our practice. I've been doing it for about 17 years, and I've probably up around 12,000 of these procedures during that time. One of the busiest groups in the country focusing on weight loss surgery, and been fortunate enough to operate on people from 49 out of the 50 states and Canada and Scotland, and it's been a lot of fun. It's one of the most gratifying, I think, surgical specialties you could do. But ended up, as you said, we did our general surgery together in Dallas at Parkland Hospital, and we have lots of war stories from that time. Then went on to do my fellowship at Duke University Medical Center in North Carolina, and then I went from there and opened practice up in 2007 in Fayetteville, Arkansas. And here I am.
So, and Josh is being very humble. He and his wife Kristen, who directs their medical weight management program, have built one of the busiest, if not the busiest, private weight reduction groups in the country. So, Josh knows what he's talking about and is the person to speak to about what we want to get into today. And we were talking a little bit about before the show. Really, what this show is going to be geared towards is people who are overweight and who are looking to lose weight, and what role surgical weight loss and non-surgical weight management, especially with the Ozempics of the world and tirzepatides, these medications called GLP-1 agonists, really where those all fit together and how those all fit together, if they do fit together. And that's what one of the things I want to talk to Dr. Roller about today. So could you give us just a little overview of weight? There's a lot of different weight loss procedures out there that we hear about. The gastric sleeve, which seems to be really popular, the duodenal switch, the gastric bypass. What are all of those? And then a second question is, how do those fit? Who gets what?
All right, so that's a great question. Basically, three main surgical procedures. And I'll talk about from the least amount of weight loss to the most amount of weight loss. So the least amount of weight loss is called the gastric sleeve. And basically what you're doing is the stomach is shaped like this. You're taking off 60 to 70% of the stomach, leaving a long skinny tube or sleeve. And so it works by limiting how much food you eat. And that's it. So reduction in calories. There is no malabsorption, meaning no part where you're bypassing a portion of the intestine. So you're going to absorb every single calorie that you put in. GI tract works completely normally past the stomach. Then you get into the kind of the combo procedures, and that would be the gastric bypass and duodenal switch. In the gastric bypass, you make the stomach small, about the size of a large egg. And then you kind of go downstream and you divide the intestine in one spot. You bring it up to the new pouch that you made, and then hook the other end downstream. So you bypass about 20-25% of your intestine. Your stomach is smaller, so you eat less. So eat less, fewer calories, and then you absorb fewer calories. And that's that combo of restriction and malabsorption. Some downsides of that procedure, there's some medications you can't take after that because it causes ulcers. And that's the NSAIDs, ibuprofen, Motrin, Celebrex, those kind of things, and steroids. So that's a little bit of an Achilles heel for that procedure. And then the duodenal switch is the one I do the most of. A couple different forms of it, the modified duodenal switch or the traditional duodenal switch, but probably 90-95% of what I do. And I like it because basically it's a sleeve gastrectomy with a bypass, where you're bypassing a portion of the intestine. And it loses the most weight with the least chance of weight regain and zero restrictions on your medicines. And a lot of things we run into are like, okay, maybe you're 30 years old and you have weight loss surgery, but what if you get arthritis in your hands in 20 years? You're probably going to want to take ibuprofen at that point, or you get a headache, or you sprain your ankle. Or in the case of steroids, you go you lose a bunch of weight, you're healthy, you go out camping and roll in a bunch of poison ivy, your doctor's going to want to put you on steroids, but you can't do that with a bypass. And so we like to do a dual switch because it loses the most amount of weight and there's no restrictions on medicines. And the sleeve is really popular. And basically what happened is when the lap band went away, like in 2012, you saw a bunch of surgeons jump onto the sleeve. It's the easiest one to do. The revision rate in my mind is very high, meaning weight loss failures. And acid reflux is a real problem with it. So we like surgeries in people that I would say 50 to 60 pounds or more overweight. And then we like medicines in people who are less than that. And the main reason is when we talk about the GLP-1s, what they basically do is they slow your stomach down, paralyze your stomach, a form of gastroparesis. And what will happen is you're not as hungry because food sits in your stomach, makes you feel full faster, and then you just don't eat as much. And you start to think about what that actually is, like not eating as much. It kind of sounds like anorexia, to a point. And we've seen lots of people on it. A lot of people take it, and the drugs can work. They'll lose but comparatively speaking, you'll lose about 15 to 20% of your weight, depending on if you're talking about Wegovy or Zepbound or whatever. But compared to the dual switch, that's more like 45 to 50% of your weight. And one of, I think, the key things, because you see everybody and their dog prescribing this medicine now. I mean, you can get it online, you can get it. There may be pathologists out in California prescribing it now. And you're like, what is happening? These people are not experts in weight loss. But what they're not telling patients is this medication is intended to be on the rest of your life. It's like high blood pressure pills. When you put somebody on high blood pressure medicine, there's not any really expectation of coming off of that in 6 months. And the weight regain when you stop the GLP-1s, like 99% of patients regain 99% of the weight. And what's even worse is that the weight that was lost, 25% of that was muscle. So when you put your weight back on, now you're even have a higher fat percentage because you've lost all the muscle. And so that's the downside, I think, to medicines. But in somebody who's got 40 pounds or less to lose, I think that's a good candidate. Probably not a good surgical candidate at that point, not enough weight to lose. It can be effective. You just have to realize when you stop it, it comes back. And cost is another prohibitive feature of the medicines. They're, for a lot of people, it can be anywhere from $500 to $1,500 a month. And let's say, you got the good one. Let's say you're 400 pounds, and you're going to lose 20%. Well, that's 80 pounds. So now you're down to 320, and you're paying $1,000 a month. Maybe you're only 40 years old for the next 30 years to lose the 80 pounds and still be 320. So yes, you're not 400, but for 320, which is still not great. That's still in the morbidly obese category. So I think that those are the conversations people aren't truly having when it comes to the drugs.
Now, did you say that 99% of patients who are on these GLP-1 agonists will regain 99% of their weight?
That's the studies that I've seen. Because you've stopped, your stomach is working again. Yeah. It's not any different than phentermine and all these other medicines, because whatever was keeping you from eating is now gone. And generally speaking, when you shut, and you know this from all the things we learned in med school and surgery and the GI tract, when you shut hormones down, other ones come up. Like, it's really hard to shut everything down. And then what are the long-term effects of shutting those hormones down? And we don't know what it is in the world of weight loss. I mean, these drugs have only been out for about 4 years. And so if someone says, well, how safe is this? And by safe, I'm not talking about, a year or two. I'm talking 10, 15 years down the road, where the ramifications of being on this drug forever. And we don't know. There's permanent gastroparesis has been reported. we see a lot of nausea, vomiting. I've had a lot of patients that have come in that have had abdominal surgeries for bowel obstructions that have been due to the Manjaro, or that's what the, their op notes say. So I don't know, and that's why I think it needs to be cautiously used, and probably by people that are experts in this, and not just. I mean, there's so much stuff you can get online now that it's kind of scary without any medical supervision at all.
How much of the complications that you've seen, because I hear about things like this and you never know what to believe anymore when you hear things on Twitter or X or Instagram, the complications that you were just referring to, so bowel obstructions that are requiring surgery, permanent stomach paralysis, how much of that have you seen or have you heard reported from patients who are taking these medicines through an online vendor where they send them a vial and a pack of syringes versus the person who is going to a clinic like yours and having somebody follow them very closely through that?
That's a great question, and I don't know the answer to that, because I can tell you this year alone I've done weight loss surgery on at least 3 people who have had abdominal surgeries to go in looking for a bowel obstruction due to the medicine. And I don't know if they got that online or from a primary care doctor or telemedicine. Um, you know, one of my friends and good patients, I mean, Laura Fluchet, will tell you, her husband went into the ER, and after being on it for weeks and weeks, and had a big pancreatic pseudocyst or a cyst of some nature that developed with terrible abdominal pain. End up going away, but had to stop the medicine immediately. And I don't think people are seeing or hearing about those things. And it's kind of like, remember that drug thalidomide that you learned about in first,
Yeah.
let's say the first drug
Yeah.
you learn
Yeah.
about in med school. And it's where it caused, the drug ended up causing babies to be born without arms, basically.
Right.
But that can also just happen to people. It's rare, it's not common, but I think, if I'm thinking back in the day, like when that was happening, right when the drug got FDA approved, it's like, okay, a baby in Washington State gets born, and it was for nausea in pregnancy.
Yeah.
That's the crazy thing. So, but a baby in Washington State, and maybe one in New York, and then one in Florida, then in Texas, then in North Dakota, and it's like, it takes a while for all of this to happen before somebody can start connecting the dots that something was the cause. And these drugs can't even be used in Europe for weight loss.
Right.
I mean, it's only in America is the market for this. And so that ought to tell you something right there. Now, we could get into all that about there's a lot of food stuff that's not allowed in Europe too, that's in our food here. So, that's a separate issue. But I don't think in general that the drugs are bad. I think they have to be used in the right person at the right time. The patient has to be knowledgeable about what they're getting themselves into. And this is meant to be, obesity is a chronic disease. This is a drug that is meant to treat a chronic disease that is supposed to be forever. And the studies have shown that when you stop the medicine, the weight starts coming back. If you stay on it, you can keep it level. But those studies are only a couple years out. So wait till we get tenure data and say, well, who's on it, who's not on it, and where are those patients now?
Yeah, I think that's one of the things that has been interesting in medicine over the last couple of years is that we've seen now, the GLP-1 agonists are kind of round 2 in recent memory of a drug that has very little data that has been pushed on the American public, or in this case, consumed by the American public with very little long-term data behind it, and is being used off-label. These are the weight loss for these GLP-1 agonists is an off-label use, if I'm not mistaken.
Well, the new ones that have come out, so Zepbound and Wegovy are their indication is for weight loss. So
Okay.
Mounjaro and Ozempic are not, but basically it's the same thing. So
Yeah.
there are indications for the new drugs, but there isn't long term data, and that's you know it's interesting because I just think back to our days in surgery when you're at presenting at ground rounds or something in front of all these people, and if you got up there and said, "Hey, I'm Jason Hall, and I have developed this new procedure, and this is the best weight loss procedure on the planet, but I've only been doing it for 2 years, but all of you guys should be doing it." They would start throwing stuff at you and yelling at you, and you're like, "What are you talking about? Where's your long
You,
term data?" You're like, "Well, and I feel like a lot of medicine's kind of going that way right now. Well,
yeah.
we're not getting some of the. I mean, it took them. Well, I won't get into this either, but it took them like 50 years to develop the polio vaccine. So that where that's going.
Yeah.
So it's just we're not. It just has to be used safely, and that's why I like surgery, because it is a tool that you give the patient, and that the patient then has it. Now, does it work 100% of the time? No, because if a patient doesn't use the tool correctly or at all, then they'll lose weight and they'll put it back on. And so just like if you give insulin to a diabetic, you actually have to take the insulin for the insulin to work. At some point but I would say 80-85% of the time the surgeries work very well. And it's life-saving. We know on average that if your BMI is over 45, you can take 10 to 12 years off your life. Over 40. If your BMI is over 40, you can take 10 to 12 years off your life. It's the second leading cause of preventable death in the country behind smoking. And now 2/3 of the country is overweight or obese. And so, we just see it give people their life back. Obesity impacts every single aspect of their life. And we, well, just for instance, my wife and I have been walking around a couple miles every day with weighted vest on here recently, walking the dogs, and mine's 20 pounds and hers is 12. And I can't even begin to tell you what a drastic difference is in that walk with the vest and without the vest. And then I think to myself, what if I had 150 pounds on me? I'm not sure I could do it. And that's why weight loss surgery is so good. You know, you take somebody who's 300, 400, 500 pounds, but that you don't even have to be that big. There are people that we see with a BMI of 35 that are diabetic, hypertensive, sleep apnea, and have had 3 heart attacks. Everybody's obesity impacts them differently. And I think that's why you look at somebody and you got to look at their family history, their medical history, and their surgical history, and then talk to them about what kind of goals do you want to achieve. And then that's when you pick the right surgery for them.
So I guess a couple of things there. One, you really need to walk around with some more weight. I've got a 45-pound pack. You need to up your game a little
I
bit.
am just starting. I am just starting.
But I will tell. I've actually had that same thought walking around. I'm like, holy cow, I used to be 45 pounds heavier. I don't know how I did this. Like this.
I know.
This is hard work.
Yeah, I mean, we did that. We all put that weight on at Parkland,
Yeah.
and we're the only thing. Just imagine this: the only thing open in our hospital when we were training at night was a McDonald's,
And we were
that's,
there. We had
that's healthcare.
you and I had more than one McFlurry at 3 a.m. on trauma call.
there is something about an Oreo McFlurry at 3 a.m. after doing trauma. So
Yeah.
it was not good for the waistline though.
Not good for the waistline at all. But fortunately, those days are behind us now. Patient behavior, I think, is one thing that anybody in medicine, compliance specifically, that anybody in medicine kind of talks about. And with obesity, there is so much psychology that's involved in that disease. And I remember from general surgery days and early on in my own plastic surgery career, there being a lot of psychologic counseling, a lot of nutritional counseling that goes in on the front end of all of these weight loss surgeries. Can you talk a little bit about what that entails?
Yeah, and so that was a big deal back in the day on the psychological thing. And so a lot of what we see is with regards to depression. I'd say at least half of our patients are on some sort of antidepressant, and that may be true for the country. I don't know the stats on that, but you know, some insurance require it, some don't. We evaluate every patient. Dr. Kristen does, or our providers, and it's most of it is going to be weight related depression. Like I can't ride on the roller coasters at the amusement park. I got kicked off when I tried to get on with my kid because it wouldn't shut. I have to ask for a lap belt extender when I get on an airplane, or when I go to a restaurant, I ask to not sit at a booth because the table doesn't move. You know, there's these things that people start like totally withdrawing from. So when all that happens, they stop traveling, they stop going out to dinner, they stop taking their kids to amusement parks, they stop going to just think about going to a stadium where the chairs are all pretty small. You know, they don't want to go to do things anymore. So they start withdrawing from life. And I think that's what you see on the depression side. And so losing weight tends to fix a lot of that. We do a ton of dietary counseling on the front end because, you know, it's the back of labels, trying to read those it's very confusing, probably on purpose, but it is hard to do. And so what multivitamin and calcium supplement and B12 you should be on, and every woman should be on a multivitamin and calcium anyway, but like what's good for me, what's a good protein, what's not a good protein, how much do I get in, all that stuff goes in on the front end. So when a patient has surgery, they know exactly what's coming and what they need to do. And the post-op long-term diet, I mean, you eat normal, it's just, you got a filet or you got a ribeye, and you're going to choose the filet because it's a lot less fat. And so it's not like you can't have steak. You have to make a better decision within that food group. And, maybe you're adding low fat ranch and a little bit of it to your salad, as opposed to a whole bunch. There's ways that your food can just start shooting up in calories. And that's what our dietitians really do, is try to put together meal plans and tell people what are the general guidelines for being successful afterwards. It's kind of simple for us though. High protein, low calorie diet is the best way I would describe it. And you make choices. It doesn't mean you can't ever have, a dessert here and again, but, or if you can't have a glass of wine. But what I tell people is that glass of wine's 150 calories. That's another 15 minutes on the treadmill. Like weigh your options so you can do that. But now they're participating, in life again. And that's the best part about bariatric surgery. I mean, we just had our big red carpet event for our practice where our patients get to get dressed up and wear their sequins, and guys are wearing their tuxes and suits. And we're taking photos on the red carpet and stuff like that. But I can't tell you how many of them, they've never gotten to dress up before. They did not go to prom. They did not go to homecoming. They've never bought a dress because they were never going to put themselves in that position. And some of the stories are sad. I mean, and one of the guys that stuck out was the last guy to walk down the aisle. He was 600 something pounds when he came in a wheelchair. And I told him, I said, listen, we're going to do this, but you're getting out of that wheelchair. And at the 6-week appointment, he walked in. That's what 100 pounds can do, and the way to think about it is 1 pound equals 4 pounds of pressure on your lower body. And that, a lot of people don't give that enough credit, like just 1 pound. So when he's lost like 300. So for him, he feels like a brand new person. He feels like he can run. But that's a ton of weight. That's a ton of weight for your body. And that's why obesity, when people are like, what are you going to do after work? Why don't you go work out? Like, listen, man, I can't even get off the couch. I'm so exhausted. And so people hear the I'm sitting on the couch, they think lazy. It's like, no, try exhaustion. That's what it is. Carrying that much weight around, it's kind of an oxymoron, but think about how strong you have to be to carry that much weight around.
Well, I agree. I mean, it goes back to talking about it, walking with a weighted pack. I mean, I think for people who are not in the morbidly obese category, put on a 45-pound backpack and go try and do anything. It makes everything harder. And so,
yeah, I did a pretty cool video a few years back. It's during COVID, when we were shut down and nobody could operate. So we did a video of walking up the stairs, and I walked up the stairs and we filmed it. And then I was talking as I got to the top of the stairs. I took our littlest one up, who was like in, I don't know, third grade at the time, 50 pounds. Like, I'm fine. Then I took up, carrying them like this, like a sack of potatoes, my seventh or eighth grader. And I was breathing a little bit heavy. But then I carried Kristen up the stairs. And she's not big. She's pretty fit, but 130 pounds. And they were trying to talk to me and film me after the fact. And I was out of breath. I was out of breath at 130 pounds. And it's like, that is what our people deal with every day. So weight loss surgery is the most effective long-term solution to obesity. There's no doubt about it. You don't have to take a medicine for the rest of your life. And it's not that medicines don't have their place. They do. And maybe they'll get, some protocols in place where people aren't, regaining their weight. And whether it's 99% or 80%, the weight regain is super high. And I think people need to understand that this is a lifelong commitment. So if you're going to be at 400 pounds down to 320, you got to understand $1,000 a month, 12 months a year, do that for 10 years. It's $120,000. It's $120,000 for 80 pounds. And that's and a lot of companies aren't covering it now because of that cost. I know, just speaking with one insurance company, they also talked about how their insurance claims for GI doctors had gone way up in the last 2 years, way up because of the nausea, vomiting. That doesn't necessarily stop right off the bat when you decide to stop taking the injectable. We had I'm trying to think of how to say this without. We were working on a project at our house and had somebody come over that was going to be a consultant and was dry heaving every 5 minutes while we're trying to have this plan. Finally got it out that he had been on the medicine but had stopped it months before.
Wow. And months later was still dry heaving.
Man. So it'll probably wear off, and it probably does in most cases. I know that there are some class action lawsuits, or I've heard about them. I haven't looked into the specifics, but and there are for any drug. That's not to say that means anything, because as soon as any drug comes out, somebody's getting sued for something. So that doesn't necessarily give it any. But you just got to be careful, and probably not just. I don't know how you feel about. You can get a lot of medicines online.
You can almost anything you want.
But yeah. And I just don't know how good the follow-up is, and the aftercare, and the instructions. And the main attractiveness of that is the cost, And I don't know, it's a tough thing to weigh, because, going through insurance, if it's got, or for the name brand, if it's $1,500 a month, I totally get it. But again, and everybody knows somebody who's had weight loss surgery and gained their weight back. And there's a lot of questions that you have to ask in, like, who is their surgeon? When was it done? How compliant have they been? Have they ever followed up with anybody? Those are the things. So if anybody wants to see some pretty awesome pictures, I always tell them to go to our Instagram page at Roller Weight Loss and go see how weight loss surgery can change lives. But we do, we probably do around 1,400 to 1,700 of these a year. And here's something that'll blow your mind. We're now doing them as outpatients. Awesome. So I've got patients that we opened our surgery center back in June, and they're going home in about 3.5 hours for the full dual switch. Yeah. So that's been fun, and it's kind of crazy because they're like, that was really nice getting to
Yeah. Oh
sleep in
yeah.
my own bed and not
Yeah.
in a
Yeah.
hospital. You know
I
this
mean, I
because
do
all
the
your
same
stuff
thing.
is
It's
outpatient.
people would much rather
Um,
recover on their couch in their bed, getting up and using their own bathroom than having IVs and beeping all night.
yes. Well, that's the thing. At the nurse's station at 2 in the morning,
Yeah.
to them that's their 2 in the afternoon. We're trying to rest, and somebody's every 30 minutes coming in, bells and whistles, dings. The hospitals are great places to recover, but they are
Yes.
horrible places to rest. And it's just the nature of what it is. So yeah, this move to the outpatient weight loss surgery has been a game changer. I've had patients that come in from all over the place, like the lady from Canada last week. She came in on Tuesday, did all the stuff, surgery Wednesday, saw her Monday. They stay like 5 or 6 days, and they're right back at home doing their thing, and then we
Yeah.
do their follow up by phone.
The
So
it is, and I think
it's a fun
outpatient
gig.
surgery is the way. There's so many procedures that are moving to, people doing total joints as outpatients now. Which when we were training, none of this stuff was outpatient. Everybody was overnight stays, admitted the day before.
So that's why you see so many people on GLP-1s after sleep, because it's the least effective procedure. And honestly, it took what 15 years for people to figure out the lap band was not a great, maybe less than that, maybe 10 or 12, wasn't a great surgery. The outcomes weren't very good, and at the 12-year mark, 51% of patients had to have their bands removed for complications. But all the people who were doing bands seemed to switch to the sleeves, and so I would say it's the easiest of the procedures to do. So are people doing a lot of those because it's the easiest? Probably. Does that mean it's the best for the patient? Absolutely not. Now, there are some situations where sleeve can be the right surgery. So I'm not saying it's not there um, for everyone, but in general, it's less than 5% of the surgeries I do. And I think you'll find practices in the country that do 100% sleeve. And that's why I
Yeah, I don't.
caution. Yeah. Go ahead.
I was going to say I don't know what the numbers are around with the practices here in Knoxville, but a vast majority of the patients that I'm seeing now
Yeah.
are sleeve patients, and the ones that have had a bypass or a switch have gone to somewhere else.
Yeah, it's not. I mean, and that's because there's not a lot of us choosing to do the harder procedure up front. But now, I mean, we've got it down where I mean, our duodenal switches take me 40, 45 minutes. So we've got a great operating team, great nurses, lots of awesome help, and we just have it down. And I think there are surgeons who are scared to learn it too. I mean, the duodenum is not something that you get a lot of experience operating around, unless you're
Right.
taking it out for cancer. So it can be a scary area, and that's something I would also caution patients when they're choosing surgeons. If you go to a practice that's doing 99% sleeve gastrectomies, you're going to get a sleeve gastrectomy. And if you say, well, hey, what about this duodenal switch? They will come up with every possible explanation as to why that's not the right surgery for you, because they don't want you to go somewhere else. If you go somewhere where they do all three procedures, then you can have that candid conversation with the surgeon about what is going to be the right procedure, because they're not worried that you're going to leave, because you're able to do all of it, and pick the best surgery for that patient. And there are patients who all three surgeries could be a great option, and that's when it gets down to really subtle things like family history of diabetes and heart disease, or things of that nature. So I think picking somebody who's an expert and well versed. I mean, there's only really three of these procedures, so it's not like you're you're somebody who's doing like 19 different weight loss procedures. And then I really caution people on the GLP-1s just to find people who are their specialty is weight loss. It doesn't have to be a weight loss surgeon, but who specializes in weight loss and does a lot of it and knows the medicines really well, and can detect early signs and symptoms of problems to come. So,
Yeah, I think that's good advice. I think that I talk to patients a lot about both on this show and in real life with respect to facial aging, because you guys have a non-surgical center, non-surgical aesthetic center in your practice as well. And, when all you've got's a hammer, the whole world looks like a nail. If all you do is filler and Botox, then if you come in for facial aging, you're going to get filler and Botox. You're not going to hear about a deep plane face and neck lift. You're not going to hear about laser. You're not,
You're
and
not going to hear about your options, about
yeah,
what all is possible. And it's like, there's three. You go from like loose skin or stubborn fat on your belly. You can do like cold sculpting, something totally non-invasive, to something like body tight, which is kind of minimally invasive, and then a full tummy tuck. And they all have their pluses and minuses. And if you're like, are you going to be happy with cold sculpting if you just see a little bit of difference? Like, no. Okay. What about here? It's body tight, and lipo, but I still can't get you, flat like this table. Are you going to be happy with that? No. Okay. Well, here's your option then. Yeah. And then that's that. I mean, those are the conversations that need to happen. What are you looking for? And are you okay with the things that come with it? And so I do think a lot of people think like the sleeve is a less invasive procedure than the other two. And I try to tell them it's actually, from a surgeon's perspective, maybe one of the most invasive procedures, because you're actually removing 70% of an organ. Like you're crossing the bridge and burning it behind you.
Cutting your stomach in half and removing,
Yeah. And so that's not, but the picture looks very simple compared to intestine, going everywhere. And I think people get picture and are like, oh my gosh. And so that is why I think the sleeve, it looks simpler to patients too. And since so many other patients are having sleeves, they think about sleeves, but we've changed that. Now people come into our place and they want to switch because I've seen so many people wanting to do a deal switch. And that's, it's okay. There's not much to it. We do the sleeve and then we add the bypass and you're done. And it works great. Now, and probably the least invasive, and people may disagree with this, but maybe the gastric bypass, because it is actually reversible. Mm-hmm. So from removing a body part standpoint, the bypass is the least invasive because you're not removing anything. So it really just depends on how you define invasive, but we're doing them all now through these, super tiny incisions and going home the same day. So none of it's that invasive at this point.
Yeah. Yeah. Things have changed a lot in the last 20 years, since we were training together, for sure. And you've helped to move that ball down the court, with your practice. Is there, I know we're running kind of up to the end of time. It's end of the day, and I know everybody wants to get home to their families. Is there any final thing that you would like for people who are overweight, who are kind of considering surgery versus non-surgical weight loss? Any pearls for them to take home from this discussion?
So I would say, yeah, absolutely. If you are that 40 or 50 pounds overweight, what you need to understand is that obesity is dangerous. It's a dangerous disease and it kills a lot of people. And it is okay to seek help for it. It's not a personal failure. It's not a personal weakness. We would do it for high blood pressure. We would do it for diabetes. We would do it for cancer. And the problem with obesity is it causes all of that. It causes all of those things. So seek help from an expert and research the options. And I'll tell you, all of our patients, they have to watch our online seminar. That's at rollerweightloss.com. You get on it. It's about 40 minutes. It talks about the procedures and our program and our doctors. But, start doing your research. What I can tell you, though, is if your BMI is 40 and higher, your chances of losing the weight without surgery is less than 1%. Losing the weight and keeping it off, is less than 1%, because we have a lot of people who lose the weight. It's the keeping the off part that becomes the trick.